Welcome back to Little Spark Big Impact, where we ignite the passion of pediatric providers like you. I'm your co-host, Mika Mitchell, here with our co-host, Joe Schreiber. And as pediatric providers, we play a pivotal role in the child's development. We educate the support system that empowers caregivers, and we celebrate every victory, no matter how small. Each episode will dive into different topics with the latest research to help you make an even bigger impact with those you work with. Whether you're a seasoned professional or just starting out, this podcast will hopefully give you ideas to support the positive impact you can have in the lives of the children and caregivers that you have an opportunity to work with. Our goals is to spark deeper thinking, reflecting, and learning from each episode. Today's episode, we will be discussing caregiver collaboration, which may evolve into many different conversations around how do we help the patients and the children and the families that we work with. So I'm very excited to introduce our guest that will be joining us today. Today we have Dr. Suzanne Campbell, who has already told me not to call her that, but I just have to give respect where respect is due. And we also have Dr. Kara Bonowitz that will be joining us to start this conversation. And so welcome.
Thank you.
Our first question to kind of get us started, as we think about, working with families, and you guys have some great experience, great knowledge. We'd like to just kind of start this off with a brief conversation about who you are, your career as a pediatric physical therapist, your research, and tell the people a little bit about yourself.
Okay, happy to do that. I've been around for a long time. I've actually been retired from clinical practice for over 20 years now, so I wanted Cara to come because she's very actively involved in clinical practice, and I think a lot about a lot of issues. I am very proud to say that I was an early professional working in the neonatal intensive care unit, and that really was kind of what I devoted most of my life to, and in particular trying to develop better means for assessing outcomes, for diagnosing delay, and it's been just an incredibly rewarding career. I have to tell you one story about how I got into this because I think it's extraordinary. I was at the University of North Carolina, Chapel Hill, and a wonderful neonatologist, Ernie Crabell, was hired to develop a NICU. So this is how long ago this was, talking early 70s, right? And he did a most extraordinary thing. He sent out a memo to everybody, every faculty member in the medical school, and invited them to contribute if they had something to contribute. Well, not being shy, I stepped right up to the plate. And together we then designed the developmental follow-up clinic. And then over some years, I moved into the NICU and brought my students into the NICU. And that was sort of how it all started. So, if I think about the evolution of my thinking about this area of practice, initially, we thought these babies born preterm, needed stimulation. And then with the incredible work of Heidi Alls and other people, we realized, oh my God, they have way too much stimulation. There's so much sound. There's so much unpatterned sound and light stimulation. And so the model became protect. But my own feeling is that if people didn't really get trained by Heidi in how to evaluate the children's readiness for new things, they sort of kept protecting. And so I've been an advocate in recent years for the acknowledgement that these babies need to move. Movement is how they develop their brains. And we need to have exercise programs going on in the nursery. So recently, both Cara and I have looked at the evidence about this, and there's abundant evidence that this is helpful to these babies.
Thank you. Cara.
So my name is Cara Bonowitz. I have been practicing physical therapy for 24 years. And so I got my start. I was working in an inner city Chicago hospital and wanted to start a NICU developmental therapy program in our NICU, and we didn't have anything. And so I reached out to Sue, and she helped mentor me on starting the program and using the a standardized outcome measure in there, and reached out to a couple other hospitals. And a couple years later, a lot of hard work, blood, sweat, and tears, but we had a PT, OT, and speech in our NICU. And then we integrated into the NICU follow-up clinic. And so I worked in there for quite a few years. And then after my babies, I transitioned out into early intervention, and where I was lucky enough to be part of one of Sue's research projects, where I got to go into the home and really learned how to do the clinical side of research as a clinician researcher, and worked for that for a while. And then 10 years ago, I transitioned full-time into academic teaching, where I went from full clinical practice to full academic and some clinical practice. And then 2 years ago, I just completed my PhD in early childhood to meld development and medical together, which is one of my favorite things to do for people in both sides of the story, medical and teacher education or development side. So I currently still work in the NICU. My dissertation was all in the NICU, recruiting infants. And so that's kind of been my journey with learning to work with families, and working with primarily babies, but did work to 3 for quite a bit of time. But I think the babies and the families are both my favorite. And I will say my journey on working with families has definitely evolved over my course of years. I've done a lot of self-work about learning to work with different types of families, and learning that there's lots of different ways to work with families, and that all families are different. So I think this was a great topic, and it's one of those really important but kind of soft or grayer skills in the area of pediatrics, of finding the balance of trying to get the families to buy in, but also making sure you're going about it the right way.
Thank you. And I think that sets this up for a great mindset, right? There's so much to learn in the collective years of pediatric practice in this space, that we have all evolved, and that no one approach is going to be effective for everybody. And I think that's where we as individuals really should just kind of sit with that for a moment. That's where maybe these little sparks will just be popping off all episodes, so that someone can really appreciate that, who you are when you start or at this moment in time is going to be different. And so part of this evolution of clinical practice, there's a shift with collaborating with parents and caregivers to then implementing home programs and activities for children to help with those motor skills. So when we think about that evolution, can you guys speak to your thoughts about that?
Well, again, a million years ago, when I was first training in neurodevelopmental therapy or BOBATH therapy, one of our Bibles was Nancy Finney's book, Handling the Young Child with Cerebral Palsy at Home. So we have always been about, I think, trying to translate what we've done in therapy into functional activities, participation in the home. So that's not really new. But I think I have not done research on this, so I don't actually know where this idea of sort of turning all of it over to the families seems to have come from. But I think a lot of it came from early childhood educators who very rightly said the parents are the first teachers of the child. And I think that idea of promoting cognitive development through helping parents through coaching sort of got moved into our area too. And I don't know that motor skills are as easy to teach to parents as play is. Play seems to come more naturally to me. So I think we accepted it as a theory, and I'm not sure there's actually a lot of research. that tells us it's the best or the only way to go, or whether there's some combination of therapeutic intervention provided by a professional as well as coaching of parents. I don't think we know what the best combination of that is.
Fair. You have thoughts about that, Cara?
I do. And I think when I was an early career pediatric therapist, I was proud of my skill set about how I could get babies to do this, and, was proud to show the parents that I could do that, and realized over the years that it was really about, just because I could do it for an hour with them when I was there doesn't mean that they can start to do it. And so, really shifted my mindset on, it doesn't really matter how good my hands are for 1 hour if I can't translate even some of that over to the parents to embed in, daily routines to not stress them out, or, things like that, that I probably wasn't making as big of an impact. The other shift I had seen is that, I had gone through the similar trainings with, the NIDCAP and reading the baby's cues and protecting the baby, and all this really individualized therapy based on what the baby was doing. And when I thought about that, I think I've worked with enough parents that I don't understand why we don't individualize it for the parents, because not all parents are the same, just like not all babies are the same. So some parents can jump into the role of having to become a nurse, and we're, they're doing all the G-tube feedings, plus they can become a therapist and hold their baby this way. And then they have to do the feeding therapist and help with the feeding, and also play the role of the mother. And they might have other kids at home. And so I just saw that kind of shift with my, teaching them, is that some parents are eager to learn and some parents are fearful or overwhelmed or need extra support from therapists to do it. And so I started backing off and not putting it all on them, saying, well, not thinking they're not compliant when actually they're maybe just overwhelmed and they can't do that portion of the baby rearing. And so they need a supportive therapist to come in to not only help them handle and teach them, but also to make sure that they're supporting them enough that they're ready to do it on their own. So even last year, I was working with a teen mom, and I says, do you mind if I show you some infant massage? And she says, no, I don't want to do that. And I was, okay, well, she told me she was not ready to learn how to do that. Now, hopefully, maybe when she got an early intervention, she was ready to, learn and do those things. So even starting to, ask, parents and say, can I teach you this, and seeing where they're at? Because I kind of joke and I said, oh, you never thought you'd have to be a nurse or this on top of, being a mom. And so that was kind of a light bulb moment for me, realizing that all parents aren't the same. So when we try to implement an intervention that is only coaching or only family education, I don't know how we expect all the families to react the same, because they are not the same.
Such great points. And I think I've definitely seen that and experienced that. But just to know how overwhelmed this could be if even just this medical side of life is not even in your vocabulary, right? So they're learning new vocabularies, and they just wanted to love on this baby in whatever they imagine that to be, and just really being okay as a provider. And I think, in podcasts past, we have talked about sometimes you have to slow down. We have productivity, there are things that we feel like we have to accomplish. But if you can't connect with this individual that needs to carry out your recommendations, you're not going to make your progress anyway. So you might as well meet people where they are. And, Cara, you talked about those soft skills. It's so powerful. And soft being such a powerful word, because without that, it's not anything demeaning. It's so necessary, right? If you meet me where I am, and I'm a product of that, just as a therapist, meet me where I am, I can thrive, right? If you consider all these other factors, I think, sometimes we just want to, gotta do what I gotta do. Too bad, so sad. Do it because I said so. Oh no. And then you said non-compliant. That's one of those words. I'm like, don't you ever use that about somebody, because you don't know what they've been through, right? Right. But it's easy to say, oh, well, they're not doing it. I can imagine why.
Yeah, when we initiated one of these discussions at CSM, Laura Case, I think it was, from Duke, said, we want adherence and compliance out of the conversation. And so I said, well, what should we say when we realize that parents might not be able to do the dose that we're expecting for their children? And she said, we can just say they weren't able to do it.
I love that. Thank you.
I love it too.
Well, but right, the interesting thing is, like, what are the factors that contribute to their ability to do it or not?
Right.
And how can we think about that in the moment, or in reflecting on patient, child, family instance, or interaction, and what are the factors that we can try to sort of nudge them to feel a little more comfortable, or maybe they're just not ready, like Kara's example with the massage. A definite no, probably a good indication that they're not ready. But why was she not maybe feeling as interested in doing the massage? It was going to be beneficial for the baby, or how hard do you push? I think those are all really interesting questions and thoughts for people that are sort of out there in the NICUs or in the early intervention settings, right in the moment. How do you figure that out?
And it's individual. It's individual what the answers to those questions are.
And you bring up a good point, Joe, because I always think about, all the brain plasticity and start getting panicky about all the neural pathways are laying down in the first couple years of life, and how to meet this family where they're at and try to get, intensity, duration of the correct amount in order to build those changes, but also meeting the families where they're at to be able to get that implemented is, I don't know, it's like an art of some sort of figuring out. And we were saying, we don't have a ton of research behind, we know what will work, but we don't know how much coaching, education, things with the families to even know what those balances are. In a current research study that I'm doing right now, I'm doing a coaching intervention with families in the NICU of infants born substance exposed. And the caveat is that they have to be there. And the intervention is, based on traditional NICU interventions that we've done in the past, on, the last couple studies of, the big intervention studies, and then things that we're currently doing in our NICU. But the biggest difference is that I'm there more because it's a coaching intervention and we're doing outcome measures and assessments. And so they're getting more intervention than just your standard 1 to 2 times a week in the NICU. And so I think that's really supporting the families with the coaching, is because then they can get more feedback on a more consistent basis versus giving them something and then asking them to do it and coming back 2 weeks later when the baby's gone like this and sick and then healthy and then, feeding and not feeding. And so then all these changes happen that they're concentrating on instead of just supporting them. I think that's one difference, just because I was with them a lot more frequently.
Yeah.
And it reminds me of what Eilish Byrne says about this, which is that within a day, within a few hours, the baby can have readiness for different levels of intervention and activity. So that, I think, is a really important point. We do need to be there often.
Yeah. It almost sounds like there's this mentality sometimes of coaching, like the therapist can really back off and cede over the intervention stuff to the family and just sort of check in every so often. But what I'm hearing from both of you is it's the opposite. Like, coaching actually requires sort of regular interaction and input and attention that supports their ability to the parents, the caregiver's ability to do these things.
And the knowledge of adult learning, how adult learners learn, so that our pedagogy is effective.
Mm-hmm. Yeah, it is it's a learning exercise for families, right? For caregivers, they have to learn, and that's a hard thing. Like, they're learning is knowledge, but it's also psychomotor skills. And how do you, how do adults, how do any of us learn things is practice and coaching and getting feedback. And, sort of ideally, that's pretty substantive, right? It's not just sort of a superficial check-in. There's a lot to it.
Yeah, it sounds like the theme is this is not easy, right? It's hard in a way that if we stick with figuring it out, right? Nothing that you learn will absolutely prepare you for it, for being able to coach or teach or to help these families with this new content. And even if they have children previously, right? This is a different experience with a NICU baby, or even if they had a NICU baby, this is a different NICU baby. And so I think giving ourselves permission, Car, you talked about your self-work. I think that is an undervalued part of who we are as clinicians and in our professional formation, that we have to get ourselves gathered together. Like, we have to check in with ourselves to see how am I showing up to help these families, right? Am I dealing with my own stuff that I'm now more frustrated because they're not able to do something that I feel like they should be able to do, right? So I think, so much of our focus is usually about what we know and what we can do, but there is so much value in, are we ready to help somebody that may not be ready? And then that journey of every moment might change, but we still have to be present and ready to make those adjustments because everyone needs individualized care. Like, that's so important. And for the novice, you need to find a mentor. I feel like that's what I got from this too.
Yeah, for sure. Not to put you on the spot, Kara, but this instances you mentioned about the infant massage, and like, how did you handle that? I mean, did you just completely sort of bail on the massage, or did you come back to it later? Any more insight on that? Like, because I think of that as like a coaching episode almost. Like, you have this idea of this will be helpful for this baby, and the individual being coached sort of pushes back. So how did that go?
Yeah, so she was kind of a younger teenage mom, and so I and she was a little standoffish, so I just kind of read their cues before I even asked her if I could teach her, because she just seemed a little, nervous. I usually do massage with them first, because it's one thing that the parents feel very capable of, and so it makes them feel really nice when they can touch their baby in a loving way, and the baby relaxes or gives back, either calms down or starts looking at them. So I do always try to start with something with the family. And then when she said she wasn't ready and she didn't want to do that, then I says, oh well, can I teach you about some of their cues? And she was okay with me giving the education. It was something with the touch she didn't want to do, but I didn't see any red flags, she was still holding the baby. So it's I wasn't too nervous that she didn't want to I wasn't sure if she was afraid to hold the baby, or if she just didn't want to do that type of intervention. So she did let me kind of give her education on stress cues and different positions to put the baby in, and she practiced putting the baby on prone on her chest, and different things like that. Okay. So to get some therapeutic positioning and extra therapeutic exercise type of activities.
I've already mentioned Eilish Burns' comments about evaluating a baby's readiness, and she just published her iRainbow system, and I absolutely adore it, because after you evaluate the baby to see what they're ready for, then she gives the parents a card with 4 or 5 different things that they could do that are evidence-based, and they get to choose. And I just think that's brilliant.
That you mentioned evidence-based and some of the challenges with research. You both have done enormously impactful work in this area, but I'm curious about sort of building research. It strikes me that maybe there are ways Kara, like you mentioned about the mom gave you some cues and you shifted or switched, or, so maybe there's like almost like an algorithm or something that you could use to guide decision making around, coaching and interventions and things like that. So you mentioned about the iRainbow and the different evidence-based choices. Like, how do we continue to build evidence in this area that can help guide some of these decisions?
I can tell you in the intervention research study, the mom, we went through phases with the mom, and so when she was able to identify interaction and stress cues, I'm not ready, yes I'm ready. So as soon as she was able to identify those, then we were able to kind of move on to the next phase of the intervention. So that was a little bit of a measurement that just really tells you like maybe her cognitive or intuition about her baby, but not necessarily like building the algorithm. I think one thing that's important is that when we do a coaching model as well, because I'm probably baby bias, is that I tend to use all my outcome measures on the infants, the TIMP, and if I'm doing neurobehavior, I do the ENDS or whatever it is. But I started adding in like a infant mother interaction scale, because if I'm teaching the mom how to interact with the baby and see if they're ready to interact, and then see if they're responding to their voices, and then that is one little scale that I feel like it helps me gauge if I'm teaching the mom the right things, because is she, it's where is she at with interacting versus, because that's like almost like a scale for like on the dyad versus just on the baby, because I have been heavily biasly baby centered, but I think looking at those kind of things about are they pausing and letting the baby interact, giving the baby a minute to, if you're cooing, are you then letting them coo back, but then those are all just education types of, I think those help me build my like algorithm. Okay, are they ready to like dive into that type of, educational piece with the baby? Are they just kind of still back on like, my baby's tired or hungry, like basic needs versus more intuitive interaction needs? That makes sense.
I think
I'm sorry, can I just real quick,
Yeah.
do you have the name of that dyad scale?
Yeah, it's called the didactic mutuality code scale.
Okay.
And so Stacy Dusing introduced it in some CSM talk a couple years back. So I looked into it, and it's one of the it's one of the ones you can use on babies that are pretty small, and you don't have to video record, which I feel like when I'm working with moms with substance misuse, like that's the last thing that they want is for me to video record them. So it was perfect for mine, but I know that a lot of interaction you have to videotape and record, but this you don't have to.
I don't think we have an algorithm yet, but I think there is a lot of information in the literature that could lead us to test them. I think probably the most common thing people use is to demonstrate either with the baby, or if that won't work, with the doll, and then have the parent demonstrate back. That's probably kind of the thing that we do the most. But there is a lot of information in the literature about what constitutes a good collaborative relationship with families. And I've just brought with me some things that Kristen Oberg found. So I'm just going to read these just so I get it correctly. She found that a perception of mutuality in the relationship is really critical, which means there has to be trust on the part of the family. And the relationship also between the parent and the infant has to be a part of all of this. And then she finds that the critical elements of successful and meaningful participation are sense making by the parents. They have to understand why this is important. And I have to say, when I look at some of the research that suggests that parents just don't do what we ask them to do, these are from clinical trials. And from the human subjects end of this, you can't really promise this is going to help a family. So I think in the clinical situation, we can be much more forceful in saying, look, this is really going to be helpful, and here's how it's going to be helpful, which you can't do in a research context. So I think that's important. Development of confidence is another one. And we talked a little bit earlier, Joe, about the MOB study, in which they did find that parent confidence increased from their intervention. And then the ability of the parent to see new possibilities for actions within themselves and with and in the child. So the parent learning part of this is just as critical as the infant learning that we're trying to promote. So I think those are very powerful ideas, and they could be tested in paradigms. And then a lot of the studies suggest how difficult the environment is for families, that mental health issues get in the way, stress, work demands, other children. We have to, I think, sensitively investigate that in terms of setting our expectations when we work with families.
Absolutely.
Yeah. So, I keep sort of circling back to this individualized, right? And so my sense is, and I don't practice in this area, and just a little bit more of a superficial understanding, but we've had this pretty significant evolution towards coaching. I know some of my colleagues here in the Pittsburgh area have undergone or undergoing pretty extensive training in coaching. And I guess I wonder if you could speak to that. I mean, we've already talked a little bit about, that's okay, but it needs to be done well and done frequently and that sort of thing. But is there anything else that sort of stands out in that evolution of that process from your perspectives?
I think for me, it was more eye-opening because my research with the intervention was single subject research design. So I had to create a very intensive fidelity checklist of exactly what I was doing. And so another therapist would come in and rate me to make sure that I am doing what I said I was doing with the families. Now that just rates me as a therapist, interacting with the families. It doesn't measure anything if the families are understanding what I'm saying. But that was a little bit more eye-opening for me too, is having to work pretty tediously hard on the fidelity checklist and then having another peer come in and watch me deliver an educational intervention to make sure that I'm checking off everything that am I being trauma informed, am I being sensitive, and then not only those pieces, but also then am I also explaining the cues, and am I asking the mom if she's understanding them, and so that piece too. And I know Stacy Dusing just talked about they did a pretty big, she didn't call it a fidelity checklist, I think she called it reliability with her study with her just at the infant conference, but she talked about creating some reliability between therapists, and watching other therapists deliver the intervention to see if we're doing it similarly. But then again, if you're doing that similarly, you can do it great. But if the family is not ready to receive all of that information and learn, there's not really things in the checklist that, in mine, that says, it just says, family needs more time, or family needs more time on reading the baby's cues, but can calm the baby, or with the different sections of, or can put babies in positions and not be worried about handling, but still isn't, reading stop cues or whatever those are. So I think some of the algorithms or checklists or fidelity or reliability can help, but I think those are still new and not well defined, if I had to guess.
Joe, what kind of models are your colleagues using? I am not in practice, so I'm not up on this. I would really like to know a little bit more about that.
I'm not sure I could actually label a specific type of coaching. It's just that there's the providers here in Pennsylvania are all required to go through this training, and there's fidelity aspects to it. It's very lengthy. I think a colleague that I was just talking with said it's about a 2-year process until you're endorsed as a successful or effective, or you're able to implement the coaching model successfully or effectively. So it feels like there's this real substantive, in-depth investment in helping therapists learn how to be better at coaching. And to me, that's sort of an interesting thing. And just kind of curious with you both with your background and knowledge, if that's obviously knowing more about what exactly they're learning would be helpful, but sort of beyond that, if that feels like that's the direction that's I'll be a little controversial here because I feel sometimes as therapists or as providers, the pendulum really swings and we go off in these directions. And maybe this is an example of that, or maybe not. I don't know. So.
Well, it sounds like another podcast topic to me.
Well,
we're taking notes. Because and I think you guys bring up a good point, and even in your questions, Joe, thinking about from a novice perspective of trying to take in all of this information, and now how do I become this provider that is recommended. But I think there's a part of this conversation that as physical therapists that we should make sure that whatever this recommendation is, depending on who is making the recommendation, and we are acknowledging this skill part of our job, right? Like, because coaching, one, what is that definition, right? And then being able to say, I hear that this is the model you want me to practice in, but this family needs more of my explanation or demonstration. I need to be there frequently because of Sue's point about this adult learning, right? Like understanding where people are, and as a clinician to know how I have to direct this. And it may not be from somebody's model of, oh, your coaching is just all hands off. It may have to be a balance of, I need to show you, but I can't do all of it for you. And I think if you guys have any perspective for the novice, for someone that's like, I want to be a peace therapist so bad, and I'm going into Pittsburgh where they're telling me it's going to be 2 years before I can be endorsed in this, like, what advice would you have for a novice, knowing what you know about this coaching model, bringing in your clinical expertise, because I feel like that is part of evidence-informed practice, right? This is the clinical expertise part of like all of these years of experiences that you guys have seen changes. Any advice you have for the novice in how to truly approach this in a way that they can feel successful, and because a whole nother side of this conversation is we need more pediatric providers, right? So I feel like we have to encourage them and encourage people and give them guidance and a way to see like this is possible. It's going to take some work. So any advice or perspectives that you can share about that?
Well, I got into thinking about this more after I realized, number one, that there had been over a dozen papers looking at early intervention in the NICU or in the first few months after hospital discharge that had used the test of infant motor performance as an outcome measure. And when I thought about that, I thought, wow, this is an opportunity to compare different interventions to see what's most successful. What has the biggest effect size? Because I had just read Joe's chapter on evidence-based decision making, and I was pondering this idea about how big an effect size do you need before you can feel like this is really powerful, as compared to this is statistically significant, but still 50% of the kids in the control group did just as well as the rest of the kids, right? So he got me onto this. And last year, I developed a lecture for infant motor performance scales in which I reviewed all of these papers that I had used the same outcome measures so we could compare effect sizes. So in the area of parents doing the exercise, the most outstandingly effective method was done by a woman in Thailand named Ray Lexkokai, and she was a graduate student of Joan Cole in Australia. But she did this study in Thailand, and her effect size for her parent home program done over a 4-month period was 4.83. And Joe knows what that means is literally every kid in the intervention group did better than every kid in the control group. Incredibly powerful intervention. So I contacted Ray, and I've talked to her a number of times, and I've tried to understand what is it that was so powerful about what she did. So we don't know, and she also didn't do any kind of long-term outcome. But she did a number of things that I think were important. First of all, she assessed the babies before hospital discharge with the TIMP and divided them into 2 groups. One group doing well, that she did no intervention for, she just followed them. The other group she now randomly assigned to an exercise home program done by the parents for 4 months versus a group that did not get, I don't think, any kind of exercise intervention. And a couple things happened with that. First of all, it took 2 months before the group getting the home exercise program caught up with a comparative group, as she called it, who had been doing well and did not get any intervention. But by the end of 4 months, they were just as good, in fact, a little better than that group. While there was a very low slope of development on the TIP across the 4 months, and they assessed every month, a very low slope of the development of the children that had not been doing well initially and didn't get intervention. So she selected children based on need, which a lot of our studies do not do. They just take everyone who's very birth weight. And what that does, if you think about it, is it kind of contaminates the data with outcomes of children who would have done well without your program in either group. So that was one thing that she did that I think is very, very important. Then her exercise program, she evaluated the family's ability to do what they had been taught at the end of each month. And they were actually at risk of being dropped if they could not demonstrate the activities. So I don't know if this is an Asian point of view, but she was quite specific about that. And she actually found that the parents, in a few cases, had 1 month when they were evaluated and they couldn't quite do it, but they never had more than 1 month. So they were very compliant, if I can still use that term. They were able to do it, in other words. Second thing is third thing, I forget what I'm on. She said that she developed this to be culturally appropriate for babies in Thailand. And I think that's incredibly important. And one thing that I think about a lot is that in this case, there was probably a very good match in ethnicity between the therapists and the families. Whereas with our research in the United States, we seem to pay no attention to whether there is a match of race or ethnicity with our families. And we know that very, very many African-American mothers have babies born preterm. And if they don't have a therapist that they trust, as Gwen Kristen has shown, they don't have a therapist that they can relate to, I worry about that. So I think it's incredibly important for us to think about building diversity in our profession and, of course, in our specialty of pediatrics, but also thinking about whether that's an important thing in research where we are coaching and turning a lot of the work over to the parents. The last thing is that she gave them only 3 things to do each month. So that's probably reasonable. And I think we may overwhelm parents because we want to work on everything. But there's a lot of lessons in this important study, and really it's the only one using parent intervention that has an effect size that's over 1. So it's a model that we should know about. It's an old study. It's over 20 years old. But it's very important. So I think novices should read that study if they're working in this area and pay attention to the activities she used and how she implemented it. And really think hard about that.
Thank you. We need to collect that reference to share and also go study. Lifelong learning.
On the IMS research page, there's a subsection of clinical trials, and you can find all of these papers that I reviewed, and that Kara is also doing a more formal analysis of under that subsection of clinical trials. So there's links to the papers, so you can find it there.
We will share that. Kara, what is your advice?
Can you hear me still? Okay. I forgot what the question was.
So really just about how would you encourage a novice with all of the things that we've been talking about, and we, you know, and then we queued you up, like we need to add to this whole as it currently is.
Yeah. So like you said, like it could get overwhelming if you're like, oh, I have to do a 2-year training to get coaching, and if you're working with young families, one of the important factors is family-centered care and being in relationship building. If you're working in really anything with peds, but I give my students a checklist that was done by Trivet and Dunst a long time ago. Are you being family-centered? And we watch a video in class, and we see if they're adhering to the concepts of family-centered care by respecting what the families are saying, and those kind of things. And there's fact sheets from early intervention for competencies, just for more novice therapists about how do you work with just more basic things on working with families, and respecting, building relationships with families where I'm a young person that comes in and doesn't have any kids, and it's hard to sometimes relate to families going through the trenches of multiple kids and therapists coming in and is finding the disconnect, but really listening more and talking less. Asking the families their opinions. They've given me more ideas than any therapist can ever think of on ways to position or do things with their babies. When I say, we want your baby to turn their head to the left side, these are some ideas, and I'll come back in the next week and they'll have like all these creative things that I've never even heard of before. So just really asking the families, as long as you're explaining the concepts to them, like, we just need to get tummy time in, to show me some creative ways you figured that out. Like, the other thing I do like to use, like you said, play is so much easier for families to relate to, is that when I do work with pretty young babies, I use a lot of stuff where they use their face and their voice, as long as it doesn't overstim the baby, because then the parents are also getting feedback from the baby of turning towards them or turning towards a sound, or watching between the parent, the two parents talking. So I try to use like a verbal or a visual cue when I'm giving them activities, just because it feels like it's more relatable and not just a motor piece, when really it's mainly a motor piece, and you're using these little things to get the baby to do things in a therapeutic exercise type of way. But I feel it's maybe a little more palatable. But yeah, there's some ideas for more novice, if you're not quite sure, you're used to hearing more family education, or coaching, meaning what, like I show and then you re-demonstrate back, or hand over hand. Like, there's lots of different ways for coaching, but I think building the relationships will help facilitate anything regardless, and that comes much easier to some people than others. So the checklists are nice.
Thank you. Those are some great tips and things for everybody. I don't care how long you were practicing, but I feel like it sounds like some good encouragement for the novice, or just anybody that's wanting to enter into pediatrics. And sometimes it can be daunting or hard, or like physically, like there's no job. Nobody seems to want to hire, but there are so many children that are in need. So, yeah, thank you for that.
Yeah, I mean, I guess that, just to sort of wrap up, where do we go from here? Like, if we heard kind of the novices and what to do, but in terms of research and or clinical practice, and encouraging all of us to strive for the best possible outcomes for children and families. Like so, what do you have a couple sentences to help us kind of wrap up and think about that? I keep putting you on the spot, Kara. Sorry.
Let me think for a second.
Well, I'll tell you some things that I think are really important from my review of the articles that use the temp as an outcome measure, where parents were doing the intervention. There were 9 of them, and only the lexical one that I mentioned had a large effect size. There was a pilot study by Stacy Dusing that's right around 1, but that's work that's not done yet. So I'm not sure how that's going to play out. But reading those articles, if you're going to do research on this, is incredibly important because lots and lots of feasibility studies are being done, and they're showing that the programs are not working. The article by Mobs, which I was very excited about because it was involving participation in rural families, 75% of whom were considered disadvantaged, and those are my people. And they were able to improve patient confidence with a program that combined telehealth with once every other week clinical visits. But they only had 45% of people they approached to be in the study agree. And then they had only 50% of the visits completed. And a major reason for that, reported by the parents for not being able to do these visits, was maternal mental health. And then they had dropouts that they had lost a quarter of their subjects by the end of the study. So it is very difficult for parents to do this, but the way that they try to engage these families with participation goals is brilliant. So again, reading these articles to look at the protocols, I think is incredibly useful. And the feasibility studies that are being done are really telling us where the problems are. And that is very important if you want to do research in this area. So while that sounds very negative on my part, because the parent initiated intervention or conducted interventions haven't been very successful, it really will help us to figure this out.
Cara, what are your thoughts?
Oh, yeah, sorry. Yes, I agree with all those pieces of, I lived in a big urban city and moved to a very rural area, and the challenges are quite different. And it's primarily because of transportation to get places. So at least in a city, you can give them a bus pass and they can get places. But if you're living in a rural area, I find it very challenging for them to even have follow-ups, with even the physicians they need to have. And telehealth really was helpful for a lot of people during, especially rural areas during that time. But now those have kind of faded, and people are, they're not paying for them anymore, and they're not being approved. And I think in some areas, in some populations, it works really well. And some families would, having them have the choice, would you rather do that than me coming into your home where you're embarrassed or don't want me in, different places. So, can you still hear me? Okay. And so, meeting the families again where they're at and working with them, just recently there was another big publication in the early intervention field about the number of babies born with substance exposure. And it went from, this is how many we had at the hospital. This is how many actually made it into the early intervention system. This is how many actually got services. And it went from, it was like 3% actually only got enrolled and started in the early intervention services. So I think the kids just aren't even, for whatever reason, the disconnect between the early identification to actually starting the therapy services. There's so many steps and gaps that we don't know why they're falling through or why they're not doing it. So, trying to maybe look at some of those.
And there are disabilities for children.
Yeah. So,
what did you say?
I said there are disparities for children of color too. It's even worse.
Yes. So.
Well, that probably seems like a good spot to wrap up. We're getting a little bit of an echo here too. So not sure what's going on with the technology side of things. But, this has been a fascinating conversation, really sparked a lot of sparks for me, very thought-provoking, and really appreciate you both spending the time with us today and sharing your knowledge and expertise and insights. So thank you very much.
Yes, thank you. Thank you. Thank you for your willingness to have this discussion with us today.
It's really fun. My first podcast. I enjoyed it. Thank you.
And that's a wrap on this episode of Little Spark Big Impact, where we shine a light on how we can support the incredible caregivers who make a world of difference for the patients we work with. As you heard today, even the smallest action can have a big ripple. So hopefully you're inspired to ignite a spark of change on your own. Make sure to like and subscribe to this podcast and on YouTube so you do not miss an episode. You can create a brighter future for caregivers and the families they support. Let's let these little sparks turn into big impact. Like we discussed in this episode, don't forget about your self-work to have the impact you desire. Thank you again for listening.